Actually, we'll start talking while we eat or finish eating. There's cookies and coffee and drinks, and feel free to dig into the rest of the food over there that the crews will eat if we don't, but you should eat it. I'll start. Drew Hazelton, the Chief Operations. For the sake of getting to know each other a little bit, know who's in the room, we just go around and we'll introduce ourselves and we'll get started. It's going to be a very informal discussion.
Hi, I'm Emily. I work here at Rescue.
I'm Newfane. I'm the volunteer rep on the board and been a volunteer member of Rescue since 1980.
I'm Peter Elwell. I'm the town manager in Brattleboro.
Harold Moon, Dummerston's representative, secretary of the board.
Gary Chapman, Dummerston Selectboard.
Eric Wilson, director of operations here at Rescue.
Karen Walsh, working admin.
Stuart Barker, Jamaica rep on the board.
Ellen Walsh, director of administration at Rescue, part-time radio ad person. You may have heard me.
The radio is excellent.
I'm Gordon Little, and I'm on the Guilford Select Board as well as also on the Rescue Board.
Deborah Chapman, I'm the Brattleboro representative on Rescue.
Lynn Clark, the Newfane representative.
Rick Hagee sitting in for Kathy.
I'm Paul Fraser. I'm the chair of Select Board in Jamaica and on the rescue squad. Job.
Yeah. Stick around for a little while. We'll volunteer you for something.
Thank you.
So, and thank you to BCTV for coming out and filming tonight for those people that couldn't be here. So, this kind of annual meeting generally put together so that we can discuss the issues that are facing EMS. Let some select board members that are not typically involved and town managers that are not typically involved in kind of the daily operation of our ambulance service ask questions, get information, clarify things that they may or may not know about the status of EMS, not only here at Rescue but in the region. So I thought I'd start off with and I'm sorry, it's a little bit blurry here. If we can make that not so blurry. That's better. What's going on in EMS in Vermont, I think, is really kind of a sign of what's going on in EMS around the country. Is that going to be too loud? I'm going to turn that off. You guys, you have to turn that off. Fan off. You probably can't hear me. So what's going on with EMS nationwide is we're struggling to get EMS providers. We're struggling with kind of the structure of EMS as it's kind of developed since the early 60s. And there's some growing pains in EMS. And I put a few articles up here. These are pretty recent stuff. You guys can't see the one on the left. This is an article of the King Sentinel about ambulance service in southwestern New Hampshire. Still struggling. 2 years of conversations going on in southwest New Hampshire with really no results so far as to how to make the ambulance system better. And then some people might say, hey, it's a small town issue. So the next one over I put up was South Burlington, because, you know, being that Burlington and South Burlington are the two biggest places we have in Vermont. South Burlington, struggling to provide coverage, requiring mutual aid units from Burlington and UVM. Next one over, St. Michael's. Again, up in Chittenden County, increased call volume. They're no longer able to serve the town of Heinsberg. Heinsberg is now searching options for how to provide coverage as St. Michael's steps away next spring. Rural EMS, ambulance company dissolves. We've had 3 of those this year in the state of Vermont. Ambulance companies that simply closed their doors. Next one over is ambulance service seeks town help, additional funding, looking to offset some of the losses associated with EMS. I bring up Chittenden County because, you know, I remember using a lot of this slide presentation with some legislators next week, and we'd like to talk about Chittenden County. This is not just a rural Vermont. This is happening in Chittenden County. UVM provides most of their coverage, 1,800 calls a year. The majority of those calls are providing mutual aid responses to Burlington, South Burlington, Essex, and Winooski. So the biggest area of our state is struggling getting EMS coverage. This is a symptom of a struggling EMS system that we currently have in Vermont. Let's talk about what we have here in this region. Rescue Inc was formed in 1966 as a non-profit collaborative between 9 communities surrounding the greater Brattleboro area. In 2004, Rescue was approached by Grace Cottage Hospital as their ambulance was struggling to take on the additional responsibility of the West River Valley towns. And in 2004, Rescue opened a second station in Townsend, and a couple years ago opened this new station that we're sitting in tonight in West Townsend, making the total coverage area for Rescue Inc currently 500 square miles, serving the majority of Windham County as well as 2 towns in Cheshire County. And I think we have representatives from most of the towns that we serve here tonight. So I'd like to point out that what makes Rescue run, what makes Rescue operate, are the people. So what gets us out the door to respond to the emergency calls are the staff. Right now we're about 75 staff members that work the emergency, non-emergency, specialized rescue services that we provide. So what do select boards want to know about? Well, they want to know about what stresses are we feeling. They want to know, I get asked regularly, how are you guys doing? Are you looking like the services that are closing up? Are you looking like the services that are struggling to cover? What are the stressors? These are our stressors. Increased requests for mutual aid. We're sending a lot of trucks out to help our neighbors. We gladly help our neighbors, but it does create stress for us. Some towns requesting mutual aid 20, 30, or 40 times a year on average. Changing staffing in our response partners. This is a big one for us. Our system, our emergency response system that we use in this region was designed 50 years ago. Rescue helped to foster the first response squads in all of these communities, and they are absolutely an asset to the way that we run our operation. Changes in those, so services that can no longer provide first response, have a huge effect on our ability to provide the ambulance coverage. And we're working very hard with services that are struggling to help support them, help get them additional people. On the other side, changing our first response model by increasing services or adding services also has a negative effect on our system. So one way or the other, changes in our first response system ripple all the way through our response. And we'll talk more about that throughout the rest of the night. Recruitment and retention. This is a problem for everybody. There are 32,000 open EMS positions in this country right now. In Vermont, we have one paramedic training program that does not have nearly enough students to fill the needs of the EMS services hiring. Keeping and retaining good people. One of the challenges that EMS faces is that we don't have the same access to public retirement that most every other emergency service does. Law enforcement, fire, the sheriff's department, the state police. All other public safety partners have benefits that we can't get as EMS providers. Again, education is limited. If you want to be a paramedic in the state of Vermont and you want to go through a state of Vermont paramedic program, you better be prepared to put about $25,000 on the table. More than twice what it costs in New Hampshire and 3 times what it costs in Massachusetts. Access to education is a huge challenge for our EMS providers. We'll talk about what we've done to help education in this area a little later. Regulation. So every town, and there's a lot of select board chairs in the room, I'm sure love unfunded mandates. It's easy for our legislators to pass unfunded mandates. Well, we have the same thing. Right now, our biggest unfunded mandate is cost data reporting, and we'll talk a lot about that later in the evening. So we have our stresses, we have our challenges. So our challenges are a lot of calls, okay? Concentration of calls. So our staff now is seeing more calls per person, more catastrophic calls per person than they've ever seen before. We are concentrating the stress, we're concentrating the workload on a smaller workforce than what we've seen before. Increasing mental health and addiction problems in this region. I'll show you some numbers later on. It's staggering what we're seeing in the field. Our aging population. I probably don't need to talk to you town administrators about the aging population, but we're struggling with the acuity of these patients. The health needs, the long-term health needs of our seniors is a stressor and is a challenge for our system, requiring us to adapt regularly the way that we treat and the way that we respond to calls. Cost data collection, this is going to come up over and over and over again, is a big deal. Cost data collection is going to lead to new Medicare reimbursement rates in a couple of years. Between now and then, it's going to lead to significant reporting requirements. The members of the board know that our monthly financial statements are now over 600 individual line items in order to meet the federal requirements. The added administrative burden is a challenge for us. Medicare rule changes. We've seen two significant Medicare rule changes in the last year that have changed the way that we have to process and submit bills, slowing down payments and causing a higher than normal denial rate as these rules are implemented. Dispatching is a challenge for us. We're currently dispatched out of two separate dispatch centers. As we move forward, we're going to have to look at collecting this data for the federal government. Neither one of our dispatch centers has the capacity to collect the data that we need for our federal reporting. Yet the federal government says it has to be auditable through dispatch logs. So that's going to be a challenge that we have to work over the next few months to solve. Priority dispatching is something that we are fortunate to have in the state of New Hampshire. So our calls to New Hampshire work through a system that dispatchers, 911 call takers work through the call and help determine the acuity of the patient so that we can send and apply the appropriate resource. That doesn't exist in Vermont, or doesn't exist to the extent that it does in New Hampshire. So quite often, we have to send out resources with partial information. We tend to over-triage. We send high-value resources to unknown medical calls because we don't have the appropriate information to send the appropriate resources. One of those challenges that we're going to be working on fixing this year. So, we serve 15 towns with one EMS system. Sometimes you'll hear on the radio Division 1, Division 2, you'll hear Keene tone us out, you'll hear Brattleboro tone us out. We serve 15 towns with one EMS system. There is no Division 2 truck, there is no Townsend truck, there is no Brattleboro truck. They are Rescue Inc ambulances that serve all of our communities. And we'll explain more as we go through. Because we're working together, every town gets more. So how this works here in West Townsend last year, actually it wasn't both in West Townsend, one was in Townsend, one was in West Townsend. We had 2 cardiac arrest patients at the exact same time. And because we share resources, because every time an ambulance leaves this Townsend station, we bring another truck, whether that be from our Brattleboro station, from our on-call staff, we backfill the station. The station is always manned, as is the one in Brattleboro. Both cardiac arrests not only got ambulances, but got ambulances with paramedics on them. Unfortunately, one of those patients did not survive, but the second patient, the second cardiac arrest that came in, was a save. In a system where we didn't share resources, that would not have been possible. We run 9 ambulances. Those ambulances can be here, they can be there. There are times there's 5 of them running calls up in the towns in the West River Valley and 3 running calls in Brattleboro. There are many days where we have 5 running calls in the Brattleboro region and a couple running calls up here. We run 9 trucks to meet the volume. There's 70 medical professionals that work as part of the organization. Fluctuates between 70 and 75. Completely volunteer technical rescue group. Some are medically trained, some are not part of our medical group. A separate group of professionals that provide high angle, flood rescue, backcountry search and rescue. So this is a slide I recycled from last year, and I think it says really what I wanted to get across tonight. We're fiscally responsible, operationally efficient, and we're innovating EMS. That's what tonight's discussion is really about. So I usually save the money slides to the end of the meeting, but if everybody remembers last year, we agreed on the rates for the next 2 years, so I can put them up front because they shouldn't be a hot topic. Okay, and the rates, we agreed to increase for 3 years at a rate of 1% a year for 3 years. Something we're proud of, 10-year average is just over 1%. And we've reduced our dependence on town tax dollars over the last 5 years. Every year we work towards reducing our dependence on town tax dollars. And we'll explain how that's happening in a minute. So, what does it cost? There's some beautiful posters. Thank you to Ellen and Karen. Take time to look at the posters around and explain the cost associated with EMS. What it costs for an ambulance to leave this organization and go on a call. Whether there's a patient transported, whether there's a patient treated or not. $623 to go out the door. To put that into perspective, Medicaid, after years of lobbying and support from our legislators, now pays us $226 for that call. And then they tax us on the money they gave us. So they pay us $226 before the provider tax to go out on that call. Create some challenges for us. Operational efficiency. If you call 911, once that call gets through the dispatch, or the call taker through the dispatch center and they push the button, it takes us 1 minute, 1.65 minutes to get out the door. That's our average out of door time for calls. Geographically, we base that at 2 stations. Anybody that's ever been on Route 30 knows that quite often we have trucks running up and down between Route 30 to move those resources around, using status shift management to make sure the trucks and the personnel are in the right places for the calls. And we're pretty good at it. Both stations are staffed 24/7, 365. Every single day of the year, 24 hours a day, we have a staff in both stations. If the call goes out, we bring in more people. If there's a call out here, we bring a truck from Brattleboro. If there's no trucks available to come up here from Brattleboro, then one of these wonderful providers sitting around the table gets called in from home. They don't get called in from home when there's a call. They get called in from home to sit here in case there's a call. Isn't it fun? And they're happy about it. Okay? Look at the smile. See? She's happy. She likes it. All right. Highly effective. 98.8% of our calls were treated by our ALS staff calendar year to date. Somebody's going to say, but what about the 1.2%? Those are interfacility transports, where we were taking straight BLS patients for BLS transports. 100% of our 911 calls year to date were transported by advanced life support practitioners. I gave us a gold star. 3 complete years, 14,000 calls, and we've not missed a single emergency call. We've not had a single mutual aid truck, mutual aid ambulance that's had to come take one of our 911 calls in 3 years. We appreciate and we thank Deluzio and Keene Fire, who have provided us paramedic intercepts when our trucks were transporting the other direction because they were closer. But we've not had any ambulances have to come into our coverage area and take our calls. So, what we do? We're busy. You can see our call numbers. The board keeps asking me, when is it going to stop? When is it going to plateau? I don't know. I really don't. When I project this year, based on where we're at this point, We're looking at another 300 calls over last year, but we won't know for another few months. So our fleet, 196,000 miles logged on calls. That's not maintenance, that's not going out to get your dinner for the night, that's not status shift management, that's actual call time. 1,600 calls where we took patients to definitive care. Now, this is really important because when we talk about taking patients to definitive care, we're talking about taking patients to a facility that can treat their medical condition. We're talking about taking patients to a specialty center where they have a doctor that can treat their stroke, where there's a surgeon that can fix their ruptured spleen. We're talking about patients whose lives depend on this transport. 1,600 trips. Boston, Albany, Hartford, Burlington, Keene, Manchester, Springfield, all over New England. That's how we're logging 196,000 miles a year. Taking patients to definitive care is time consuming, resource consuming, but absolutely essential to saving lives. So what do? These numbers, just mind-boggling. By far, the most calls that we do are mental health related. We have a mental health and substance abuse problem in this community. It's not one town. It's not Brattleboro. It's not Townsend. It's not Newfane. It's every single town. I don't share call data where these calls are located. We protect that information. But 955 mental health related calls. 68 assaults, 10 gunshot wound or stabbing related incidents. 331 patients considering suicide in 1 year. Compared to 244 that we treated for potential heart attacks. These numbers didn't look like this 10 years ago. This call volume trend I showed you 2 slides ago is not an increase in cardiac patients. $57 cardiac arrest patients. Where did we go? What did we do? Well, the majority of the calls are in people's homes. So we got housing, streets, and apartments. That's the majority of what we do. A whole bunch of little weird places that we seem to go. But most of those are people's homes. With that, 46 patients transported on ventilators. Something you didn't see 2 years ago because we didn't have ventilators. Almost 2,000 IV starts. 24 fire scene rehab events. One of which we rehabbed over 50 firefighters. Eric remembers that day because we had 51 calls in 24 hours. I think everybody remembers that day because I don't think anybody went home. I can't go through a presentation without, a kudos to our training center and the work that they do. Not only do they train our staff, but they train the hospital staff, the nurses, the doctors, advanced life support, basic life support, pediatric life support. Sorry, that's funny. Our training staff provides our EMT courses, our advanced EMT courses, our continuing education for our providers, and the continuing education for the responders in the area. In fact, tomorrow night we'll be teaching Narcan administration to firefighters. Next month we'll be teaching first aid to the Jamaica Fire Department. Our training staff is out constantly helping to train our responders. So, what does it look like? So imagine for a moment what an EMS system looks like that's dedicated to advancing EMS. Probably an EMS system that takes pride in the fact that we respond to all of our calls. Takes pride in the fact that we transport these patients to a facility that can treat their illness. But how do we do that? when we get reimbursed a third of our costs. How do we do that when we have challenges that we listed earlier? And we do that with support from our community. We do that with support from our donors. I'm going to go through a few of them. Holt Foundation provided us with a grant to purchase a high-fidelity patient simulator. Somebody in the room is like, isn't that a mannequin? Nope, this is not a mannequin. This is $50,000 worth of high-fidelity patient simulator. This patient simulator is designed to work with our equipment. These patients can be on ventilators. They can be on cardiac monitors. All the readings from this patient simulator come right straight through our monitors as if it was a real patient. In fact, there's some sort of, and I'm not a computer guy, artificial intelligence inside that knows when you treat it right and when you treat it wrong. If you do good, it lives, and if you don't do good, it doesn't live. How that part works is outside of my understanding, but high fidelity patient simulation to improve patient care. What else this does for us? It attracts good providers. Good EMS providers want training. Good EMS providers want high-end equipment so that they can treat their patients. The EMS Fund. The EMS Fund donated all the funds for equipment and training for the first of its kind pilot program for field ultrasound. We kick off October 1st with the first field ultrasound project in Vermont's history. We're having 6 paramedics that will be studying the effectiveness of field ultrasound, the outcomes on patients. So they collaboration with Dartmouth Hitchcock and UVM Medical Center. We're doing actually 2 side-by-side studies, one on the ultrasounds and the other on the providers and the education. Very exciting breakthroughs in medicine for us. Thomas Thompson provided us grant funding for CPR feedback mannequins. These mannequins now monitor your breaths, monitor your compressions, and are able to give you direct feedback as to the quality of the CPR that you do. We now practice high performance CPR. High performance CPR is saving lives. We've seen more patients survive sudden cardiac arrest with high performance CPR than we ever have before. These mannequins are now not only for us, not only for medical responders, but we're rolling these out in the community for the public. Another program we're starting with our high fidelity mannequins starting October 1st is free CPR classes for all students and educators, with a target of 1,000 students in the next 12 months. We want to be a heart-safe community. We need to get this information out, and the high-fidelity mannequins and the feedback CPR simulators will help us get that message out. Brattleboro Subaru, one of our biggest supporters. We've been doing fundraising with Brattleboro Subaru for 6, 7, I can't tell you how many years, as part of our Subaru raffle. Combined fundraising dollars over $200,000 that we have received from Subaru and fundraising with Subaru. We were able to purchase power stretchers with our fundraising dollars, which has allowed us to reduce back injuries. We actually had a 100% reduction in back injuries with the power stretchers. Share the Love event. We were fortunate to be the recipients of the Subaru Share the Love event. We were working towards a purchase of additional equipment with that funding, which is going to allow us to sterilize the back of the ambulances. Right now, we have to clean with hand wipes, disinfectant. We're moving to a system that is much like you'd use in an operating room, so that they can be completely sterile environments when we're done cleaning. So, education. We were fortunate to receive a grant from the Department of Labor, some additional funding from the EMS District 13, and Rescue Inc sponsored the remainder of an EMT class. We recognize the need for first responders. Our system depends on our first responders. Overwhelming support. We had 24 slots. We had 71 applicants. We decided to run 2 classes. We're now running 48 new EMTs through training. And if you look at your town, these are the numbers of new first responders that you'll have at the end of this class. Our region is benefiting from the grants from the Labor Department, the district, and the work that our training department is putting in putting out these new first responders. We're almost there. Leader Beverage is helping us sponsor our adventure race this year. With Rockstar Energy Drinks, we're actually kicking off a fundraiser to support our specialized rescue teams. Our teams provide all the swift water, backcountry, flood rescue for this region. We're actually part of a state response team for Vermont on the search and rescue and on the flood side. So Leader Beverage is one of our sponsors and is leading that raffle for us. And please take information when you go. Vermont Homeland Security provided us with our first off-road rescue vehicle to support our search and rescue and swiftwater rescue team this year. As part of our state response, as part of our state MOU, to provide swiftwater, flood rescue, and search and rescue. They're providing us with a UTV, which will also be able to support some of our other standby operations like 4th of July, Strolling the Heifers, and some of the other parades and functions that we do stand by at. So community outreach, something that we really strive to push out in the community. Last year we kicked off a Stop the Bleed program with a target of 1,000, similar to our CPR initiative. We kicked that off in November of last year. I'm pleased to say we were over 900 students and on target to meet our goal of 1,000 by the 1st of November. We've also put 50 Stop the Bleed kits out in the community. Places that we've done Stop the Bleed are most every fire department in the region, businesses like Sosimo, Putney Paper, every one of our schools has had this training. So we're very pleased with the Stop the Bleed program. Our bike team gets out and covers events, 5K races. We do coverage at the Strolling the Heifers, the 4th of July parade and fireworks, as well as the hospital fair, the hospital races up here in Townsend, Hinsdale fireworks, graduation, you name it, and they're covering those events with our bike team. We do a lot of outreach with youth. A lot of youth programs come in, learn about ambulances, learn about what we do. We also sponsor a Boy Scout troop. Youth program is important to us. This is our group of boys with a couple of our technical rescue volunteers teaching them ice climbing as a safe alternative to what kids do. So our subscription program. Annual subscription, $60 per household. Helps our seniors, helps our fixed income folks. If you're a person that doesn't have the resources to pay that bill, become a subscriber. That money gets pooled and helps offset the high deductibles or the co-pays that exist as part of your insurance programs. And if you want more information, Ellen is the expert on subscription programs. If you guys have questions, you can answer. I don't have to keep talking. You give me the answer, I'll give you the question. All right, so what's up? What's coming next? Well, Medicare rates, I told you last year, stable for 2 more years. So we know what Medicare is going to do. It's the first time in a long time that we know what Medicare is going to do for 2 more years. Year 3 is the cliff. What we don't know is what happens in year 3. Because what happens in year 3 is based on this timeline. This is cost data reporting. There's the cost data reporting cliff. The first cost data reports start January 1st of 2020. They are due March 1st of 2021. They're going to take that data and determine whether they pay ambulance services enough or too much. If they think they pay us too much, they will cut our rates. So it's very important that as an industry, we get our cost data reports right. The home health industry went through this about 5 years ago, and at the end of their cost data reports, they saw reductions of 50% in their reimbursement rates. So if I didn't tell you that makes me nervous, it makes me very nervous. Because the data is not ours. They're going to aggregate all EMS data for a region. So even though we have spent hours, countless hours, making sure that our data reporting systems meet the federal requirements, I'm not sure that everybody else has. And if this data is aggregated and we get bad data, we stand to lose significant revenue under the Medicare program. So that is one of the biggest challenges we have in the future. The State EMS Advisory Committee was formed by the legislature 2 years ago, or reformed, I should say. I actually chair that committee. That committee is doing a lot of work, and we will be actually presenting a report to the legislators this year, requesting changes to EMS and the EMS structure in Vermont this year. Looking at everything from funding to education and in some of the ways that we do EMS delivery in Vermont. We've had a 2-year study on what the root challenges are in EMS. What is really the problem with EMS education and how do we fix it? And anybody that's really interested in the nuts and bolts of those, we'd like to share after with you. So what's new at Rescue? Lots of new things at Rescue. So in the last year, we replaced 3 trucks in order to keep up with the demand of the mileage. There's 2 power stretchers here, but we've replaced 3. Got our off-road vehicle, patient simulator, ultrasound. Lots of new at Rescue. I can show you pictures of the new providers too. But we have new excited EMTs, advanced EMTs and paramedics. So we started here with stress. And I'm going to end kind of the same place. So as an EMS system, we are facing stress. The stress, increased requests for mutual aid. Not a whole lot we can do about that. Our system, our area, our region is struggling like everywhere else in the country. It's important to us to be able to help our neighbors. We will continue to do that as long as we possibly can help our neighbors. Changing our first response models. This is huge for us. A loss or a change in a first response service means the difference between us being able to provide the service and not. This is where everybody is on the same boat. There's 15 of us in the same room. The service you're getting right now is second to none. Little changes can change that in a hurry. I talked about staffing, recruitment, and retention. Our plan to deal with staffing, recruitment, and retention, I just showed you. EMS innovation is how we're going to attract and maintain the right people. It's through ultrasound, it's through high fidelity simulation, it's through engaging the healthcare providers that we want to stay here. How do we help staffing? We went out and we found the money to provide free EMT education in this region. First time it's been done in the state of Vermont. This project that we're on right now is being studied to see if it could be duplicated in other areas. When we put these classes forward to the state, they expected numbers in the teens, 10, 15 students. When I called them up and said, I need you to give me approval for a second class because I have 71 applicants, they thought I was kidding. This model is working. We saw the stress. We're addressing the stress with access to EMS education. Regulation, we started early. Ellen and I have spent days. We've traveled to seminars all over the country to become the regional resource for our ambulance services. I'm not going to tell you I know everything about cost data reporting, but I know way more than I want to about cost data reporting. We're working very hard to make sure that the ambulance services in our region report their data accurately. the aggregated data that comes from that, we all have to live. We all have to live with the results. So because of that, it's important that we educate them. We're out, we're educating, we're helping, taking phone calls from towns, from service heads, from administrators. What do I do? And my answer usually is, you should have done it last year. You need to change your books. If you're an ambulance service that's on cash reporting, you have to switch over to accrual-based accounting. That's not an overnight process. If you don't have your expenses broken out in a certain way, you've got to do that now. We're working very hard to try to minimize that effect. I don't know what's going to happen in 2 years when they pull this data and they decide whether we've been paid too much or too little. We'll see what the result is of our work in a couple of years. So here are my pictures. We've had a really fun year. Since the last time we met, we've had a really fun year. Almost 1,000 Stop the Bleed students. Fun people, by the way, really fun. Educators, getting educators covered in fake blood is an absolute riot. We had a good time with them. Water rescue training, confined space training, traveling around with our soldiers, recognizing them, CPR classes. Unfortunately, preparing for the worst. Tactical combat casualty care. Training our staff to use ballistic vests, helmets, tourniquets, and wound packing. So, why do you want to be part of one EMS system? What's in it for you? As a town select board, as an administrator, as a town manager, why is it you want to be part of 15 towns in one EMS system? This is what you get. 365-day coverage, 24 hours a day. It's been proven pretty reliable. Transport to definitive care. The people in your community, the guests in your community, not only are getting treated here for what their medical or their traumatic injury is, but they're getting transported to the facility that can actually treat them. If that is in Boston, Hartford, Connecticut, Albany, New York, as you saw on a previous slide, we'll take them there. We will take them to the hospital that serves their needs. Specialized rescue. Expensive business to be in. Lots of training, lots of equipment. The only way you can stay current, safe, and effective in this world is to be regional. You've got to have the support of large numbers of people, boats and resources, ropes. Each one of your towns has its own technical rescue team because of this. In fact, we were hanging off a cliff in Hinsdale on Tuesday and off a cliff in Jamaica on Sunday. So it does, Paul gets to come hang out with us sometimes. So you get both. And you get drones. Event coverage. Whatever you have for events. We get called all the time. Graduations, parades, protests. We're there. We provide the coverage wherever the coverage is needed. Large incident rehab. We do this for the fire service. We also do it for law enforcement. People will think about law enforcement, but they've kind of come around to this idea of not dying on the job. And we're now starting to do rehab for law enforcement. Divers, when they're in the area, we'll do rehab for. Medical monitoring and hydration are a couple of things that we work really hard to deal with at large incidents. Community outreach. Whatever we need to do to get out to our community, we're pushing. Stop the bleed, first aid, CPR training. Youth programs. We want to bring these kids in, we want to educate them, and we want to get them making healthy choices. We really enjoy our youth programming. Responder education. You got a first response team. If you support a local fire department, a local first response team, chances are pretty good they're educated here. Chances are pretty good their continuing education comes from here. more than likely, the supplies all came from here, because most of them get them from us. Incident planning and command. We're part of every single mass planning incident, hospitals, schools, facilities. Every single one of the towns calls looking for planning, looking for support, looking for somebody at a command post, and we provide that. I did the math for you. 6 to 8 cents a day, depending on where you live, is what it costs each citizen for our service. And I'll take questions if anybody has them, comments. If I missed something, somebody else wants to chime in.
I'll jump in to start. First of all, great informative presentation from my perspective. Even though I'm on the rescue board, I learned a lot, just walking through this again. From Guilford's select board, two things. One, thank you for putting forward the 3-year contract. The increase was reasonable, and it allows the town to certainly plan moving forward instead of waiting and then figuring out what the number's gonna be. I wanna come back to something you talked about a little bit, and that is the 15 towns that represent what Rescue is today, helping you forecast that number that allowed the towns to have this 3-year deal. And I guess the thing that keeps coming up that we think about is what happens if one of those towns pulls out of the membership? Where does that put the other 14 towns, or less, depending on what happens? But how do you, is there anything more you can talk? You said it would impact it, but can you be a little more specific as far as what that might mean, to the group?
Yeah, so it certainly depends. The significance would depend on the town, the size of the town, the number of call volumes from the town. Obviously, the larger the town, the bigger financial impact that it would have. But the reality of the situation is that our funding is made up of 2 parts. One is the amount of funds that we receive from the towns as a subsidy. That's the numbers we're talking about here, 6 cents a day per person. That's one chunk. It's about 18% of our operating budget. The other piece is the funds that we receive from Medicaid, Medicare, health insurance. So those 2 make up the bulk of our funding. We have other funding sources outside, like the grants and donations that are helping us support our capital needs. So they're not in the operation, they're outside in our capital plan. So if the town was to decide, hey, I don't want Rescue to provide my service anymore, that cost would get shifted to the other 14 remaining towns. We'd be at a point where we have to sit down and have that discussion. What do you want for service? The cost of the service is what the cost of the service is. We can't reduce overall cost and still provide you the same level of service you have. So the costs are going to go up. You can see anything from a 10 to 100%. It depends on who needs what it looks like. It's a threat. Certainly, it's a threat when you have 15 towns working together. One pulls out. The other way. Let's go the other direction. Because this is a conversation that we have had with communities from outside asking us, hey, can you provide us with a proposal for service? And our answer is, we can't do anything that's going to hurt the 15 towns that we serve. So if you ask me to go provide service to XYZ town, and there's a chance that is going to reduce the coverage we currently provide, we can't help them. What we serve are the 15 towns that we serve, unless the board decides to do something drastically different. That's what we do. Good question. Someone's got to have something burning.
One comment I have, being on the truck committee, we meet 2 or 3 times a year on the ambulance situation. A couple of years ago, we figured we had to replace 1.3 ambulances a year to stay even. And then as the call volume goes up, we get up to 1.5. Now we're up around 2, just to stay where we are now. So that's why you see, one new ambulance and one remount this year. And one going out soon.
But keeping up with the fleet is a challenge. One of the other kind of factors that's playing into it is the availability of certain chassis that we had before. We can no longer buy diesel chassis, we buy gas chassis that have a shorter lifespan. They also burn more fuel, which is giving us a higher than normal fuel costs. So there's a lot of those moving parts inside of that increased call volume. We're wearing out trucks at a rate that was not supported in our capital plan because the call volume continues to increase. Double digits, 10% a year is a lot.
Yeah, that's a question. Yep. Me and Jamaica are struggling, obviously, as you know. Are other towns staring at the abyss the way we are?
So, yeah, you're not alone. First response squads everywhere, ambulance services, no different than volunteer fire services, are struggling with getting boots on the ground, getting people. And that was really why we pushed so hard to get this EMT class up and running. That's why we've worked and we are working with your fire department to train additional volunteers. How do we get more people engaged, more people involved in our emergency response? And I've heard from more than one first response squad that's like, you know what, we're done. We can't do it anymore. And we go, no, you can do it. Tell us what we can do to help you because we want you, we need you. Our system is dependent on stable first response. It's very important. Just put it in perspective, and it depends on where you're at, okay? So if you're a person that's having a medical emergency, and that medical emergency is the next house up from our station here in West Townshend, first response, probably not super critical, because there's a staffed ambulance right here. So like in Brattleboro, the time difference between a first response showing up and an ambulance showing up is 110 seconds. Putney, it's 8 minutes. Wardsboro, North Jamaica. So when we start looking at first response and the value of first response, it's almost like backwards. The areas that have the resources and have the first response are probably the areas that need the least first response. The areas that have the fewest calls and that are furthest away are the ones that really need the first response. And those are the areas that we're really, really focusing on trying to get first responders to. Can we get first responders out to the far ends of Guilford, the far ends of Vernon, places where we can't get an ambulance there quickly. There's only so fast that you can close 12 miles. And the other thing that we were looking at, and from a state kind of education perspective, what's really interesting is for many years we've focused on advanced life support in first response. What's really changed recently is what we're determining is that the added requirements, and some people in the room will probably nod your head, that go with pushing that advanced in first response, with the credentialing, with the state mandates, has actually caused those services to nearly collapse. So we're watching these services now say, well, wait a minute, I can't support that level, so I can't support any level. Well, really, when you start looking at the numbers, basic life support, that EMT level, that class that we're graduating in January, those are the people that save lives in the first 2 minutes. I recently did some reviewing of numbers to find out how long on a scene, how long before advanced life support actually steps in. When we start looking at those numbers, so if I arrive as a paramedic on the scene, I'm the first one there, how long before my skills, my paramedic skills, are needed before lose EMT skills? Really, you're talking about 7 or 8 minutes. So when I start looking at our response areas, and I talk to chiefs of, or service leaders, I'm like, basic life support is where it's at. If you want to save lives in the world of first response, basic life support. The more people we can get on the road with AEDs, CPR, first aid, and bleeding control, the more lives we can save. In fact, if you've got a choice between spending $25,000 or $30,000 on a cardiac monitor or spending $1,000 on 20 AEDs, I'll tell you, and our medical director will tell you the same thing, buy the AEDs. There's never been a first response squad that has saved somebody's life doing a 12 EKG. We had a gentleman, maybe 2 weeks ago now, 2 weeks ago, somewhere in there, AED in his business, dropped in front of a coworker. They grabbed an AED, started CPR. They shocked him twice. They were sitting up and talking when the crew arrived. Bystander CPR and AED save lives. First response with AEDs, CPR, and bleeding control save lives. That's where we're at, and that's going to be the educational model that's going to get us over this hump of first response and get everybody kind of back up and running.
I think I know the rest of you guys know what I said. We're facing this. We have like one EMT in town. And the reality of the matter is, because of the historic understanding of the rules, fire guys aren't allowed to touch anybody. So firemen aren't showing up for these things because they're not allowed to do anything. So what we're doing now with his help is training all the fire department, the firemen, on this sort of stuff. So we can launch a truck and get somebody there to do basic, scene safety, scene control, bleeding, breathing, and comforting. It's better than nobody showing up at all until we can get some response. Because there are times when you guys are busy. I don't know if you noticed that or not.
We've been busy before.
Yeah. But the idea, though, is that also it includes a sense that the firemen are now able to do something and not just stand there and close the ambulance doors. So it really does help us, and I don't know about the other towns, but to get that kind of basic training, it's not BLS technically, but the basic emergency training, it'll make a huge difference. I'm convinced it's going to make a huge difference. And Stuart and you guys are putting this thing together, and I know there's guys interested in it, and it's very frustrating for the firemen to show up and close ambulance doors, even if they're the first ones on the scene. Not that we don't mind closing the doors, but the first ones on the scene ought to do more than just say, don't bleed to death, we got somebody coming. So this is a major help for us.
Yeah, we're here to help. Like I said, we want to support first response. Whatever it is that we can do to help you guys, we're here to help. The key is that we're all in this together. That's what's made us successful for so many years. That's the reason why we can get 6,500, 7,000 calls through the system without mutual aid. It's because we have a really good, strong system. As long as we're careful to support our system and not do things that are taking away from our system, then our future is good. Right up until the cliff of Medicare, and then I don't know what's going to happen. But right now, looking forward 2 years like this, we're in a really good place. I think the EMS innovation is going to bring and retain high quality providers. I think the model of EMT courses that we're doing now and the first response training with the fire services is going to yield huge results over the next few years. You saw the numbers on the map of new responders in the area. I think we're going to reverse this trend, and this is going to be the pilot program that's going to show the state how to get out of this first responder shortage. We're going to do it. It's going to happen right here. And the next 2 years are going to be good for us. I see lots of good possibilities, collaborations. We're working really closely with some of the other ambulance services in the southern part of the state on joint projects, and I think our future is solid.
One thing they never mentioned was in-house maintenance here and how that's affected and helped to keep vehicles on the road.
So yeah, in order to travel like the 300,000 miles that we do a year, 196,000 of them with patients, another 100,000 without, we couldn't do it without our fleet mechanic. So having a full-time fleet mechanic, trucks are, downtime is almost none. fluctuate in and out, and we've never had maintenance to this standard before. It's incredible. So yeah, it's a huge plus for us, a huge win. We're able to schedule and do preventative maintenance on schedules that we just couldn't do before. So, and another EMS provider. So it also helps to have additional.
We've seen him when new eggs are around.
When we get busy, the mechanic may show up looking like a mechanic, but he is a fully trained and qualified EMT with grease on his hands. Yeah, I think he watches them before he goes out on medical calls. Thank you, Lewis. Good
And
point.
he has to also put on his fire chief.
And he's also the local fire chief, so we kind of serve that purpose as well. So he leaves here and goes to fire calls. And again, it's a collaboration. We're all in this together. So, yeah.
Just curious, since the whole scene seems to be changing, how are you dealing with training for first response and other personnel for all these mental health crises?
There is $1 million question. So this is a topic that I'm really interested in. There's a whole bunch of sessions coming up over the next few months on how to deal with first responder mental health issues. The challenge that we're facing right now is that there's about 15 or 20 different groups that have all siloed their own little approaches to EMS or first responder mental health. There is no one program right now that you can say, this is how you address it. It's a problem. It's a huge problem. What we're seeing in the field, the quantity of what we're seeing in the field is much greater than we've ever seen before. So the answer is we don't have an answer. I was actually down meeting with the fire chief in Brattleboro a week or so ago, 2 weeks ago, having this very discussion. And I went down to say, have you figured it out yet? And his answer was, no, but when you figure it out, let me know. I'm like, no, when you figure it out, you're supposed to tell me. Because we don't know. Law enforcement's got a model. Law enforcement model doesn't really fit EMS very well. Fire service kind of has a model, but it doesn't really fit rural EMS either. So I don't know, but we're working on it. All right.
Oh no, I was just wondering. I mean, because the numbers.
Yeah.
When you start talking about mental health issues, you're kind of shifting away from where all the training usually goes.
Oh, you're talking about those? I thought you were talking about our mental health issues. I got plenty of mental health issues. No, training education, that's actually something that we're looking at. The other piece that's changing right now is polysubstance overdoses. So, you've heard a lot in the news about heroin. Like, we've been treating heroin overdoses in our sleep. Most of us probably have, because there's so many heroin overdoses. Well, it's shifting now. So, welcome to polysubstance. Welcome to meth coming back into town, which nobody wants to hear, but it's true. So now we're having to shift the education for our staff to how do we treat and how do we manage mental health patients, substance abuse patients that are now on multiple different medications, and the violence that then comes with that. So that piece is actually the easier part. Teaching the staff, training the staff to deal with the patient's mental health issues is way easier than us trying to figure out how to deal with our mental health issues. Well, think about it for a moment. A typical day at Rescue. So somewhere around 30 calls are going to come and go. You start off your shift in the morning, and you go out on a motor vehicle accident, some minor injuries, you take it off to the hospital. A little while later, you get a cardiac patient that comes in, older gentleman having a heart attack, you take him to the hospital. Then you pick that patient up and you go to Dartmouth load. So by the time you get back, it's 3 o'clock in the afternoon, you treat 2 patients a typical day. Now you go out on a patient who is a 5-year-old cardiac arrest. You work on that cardiac arrest patient, and the child doesn't survive. Come back to the station, you clean up your ambulance, and you still got 9 more hours. The next patient that comes in is another car accident. That's got a kid that got ejected from a car. How do you train somebody? How do you teach providers to deal with the stress of that repeated, constant exposure to stressful situations? And that's what I don't have an answer to. We've seen good providers come and good providers go as a result of these. And the answer isn't, Emily, you can take the rest of the week off. Because if I sent Emily home, then the next call would have been Eric's, and I would have sent Eric home, and then there'd be nobody to take the calls. So we don't have that luxury. So our providers end up finishing the shifts. In fact, usually on those days, you end up working over. Because if we're having that type of day, we have that type of day. It's at 50 calls later, we're still having that type of day. And nobody gets to go home, nobody gets to work through it. So, tough topic. Human resources is going to look into it. Good question, though. That's the toughest question of the night. I wish I had an answer. I don't. If anybody else has an answer or hears about an answer, like the magic EMS mental health, like send
No,
it my
because
way.
everybody, as a person, he takes it differently than she would take it differently. So you're dealing with complexity on complexity.
It is. And I try to explain to people, a broken arm, you do an x-ray, you see that it's
Easier.
broken.
It's easier.
You can't take an x-ray and tell what's going on. I mean, nobody knows what's going on in my head, but nobody, like, you just can't. And that's what makes it so complicated. Any other questions? Comments, concerns? Any services that you need that you're not getting? Anything that we should be looking at as we move forward over the next year for changes that you're seeing, feeling, that I may not have thought of?
I do have a question that's sort of, now that you're getting to the writing out of the things to ask questions about. We have, and you have, in a number of towns have the same situation, where there's a certain number of, we refer to as frequent flyers, but you guys know what I'm talking about, that are transportation challenged. And I know that you guys have done a lot to work on that problem. Is there anything you can do to address the chronic frequent flyers that get you there and don't want to ride?
So that is a challenge. So there are many patients that have that are high utilizers of the system and are using the system for primary care, using the system for companionship. We have a lot of repeat overdose patients. So depending on the situation, depends on what our response to that is. So we do work with the hospitals and their community health teams. So if there's a high utilizer, so if we start seeing, a repeat patient, maybe their home situation is not good, maybe their medications they aren't taking, we can reach out to the community health team. We can reach out to their primary care. Quite often what's happening in those situations is that their primary care physicians are unaware that they're utilizing the system. You'll find this hard to believe, but in 2019, where we stand right now, we are mandated to report all of our patient charts into a state reporting system that does not talk to the hospital's reporting systems. So we could go out and treat that patient 25 times, and their doctor, unless they told them, would never know.
Are you able to, without blowing your HIPAA requirements, able to communicate directly with the provider?
So we can.
Record?
So it doesn't violate HIPAA for us to communicate with their primary care because they're part of that healthcare team. We also have a medical director that will get involved in those discussions. If it becomes necessary, our medical director can go doctor to doctor. Those are actually, as far as getting services, those are the easy ones. Because most of the time those people are really looking for help, so getting them to accept help is easier. The ones that are more challenging are getting our overdose, substance abuse, and mental health patients into treatment. Because on the other end, when we pick up that patient and we treat them for their overdose, we treat them for their mental illness, and we take them to the hospital, there's no place for them to go. These people are ending up in the hospital and stuck. They know it, We know it, the hospital knows it. They end up in the hospital, and we see these patients there for weeks. Think about this for a minute. If the last time you said, yes, I want your help, I took you to a facility, they locked you in a room for 14 days before they could find you a placement, would you go with me again? So convincing those people to seek treatment, there's no treatment for them. Our system is broken. Our mental health patients are getting recycled back into the community over and over and over. It's failing. And I feel terrible for these people because I know the outcome. I know that we're going to take them into a hospital setting where there is no mental health bed for them. And if you didn't have a mental health issue, and I put you in a room, in an ER, with the high stimulation of an ER for a week and a half or 2 weeks, you will have a mental health issue by the time you're done. And those patients, unfortunately, there's not much we can do. We refer them. We explain to them that they need services, but we can't get them services. So what we do is we go back and we see them again tomorrow, and then 2 days from now. It's very sad. Talk about adding to the stress of our providers. I recall one particular patient 5 times. On the 6th time, the patient was deceased. You can only do so much, and there's no place to refer this patient. Good question. Now you're asking all the tough questions. I should have let you guys leave earlier.
We're competing for them.
Tougher questions there.
Like how long is it going to take an ambulance to get to my house? That would be an easy question. Any other questions?
I got one other comment.
Sure.
Seeing we have some community members here. If there's anybody in your community that you think might be interested in becoming a part of the Rescue Inc board, we have 3-4 at-large positions available. Correct?
We do. We have at-large positions available on the board.
And we're always looking for.
I'll give you my public service announcements at the end. I wouldn't, there's no way, Deb, I would let everybody leave without plugging a car raffle. So I wanted to get done with the actual questions before the public service announcements.
You just haven't had your tickets.
So, annual fundraiser that we have been very successful at purchasing our new power cots is our car raffle. Deb will gladly sell you car raffle tickets. You can buy them online, $20 a piece, 6 for $100. So take advantage of that. That's what supports our capital needs. So, and Deb is almost out. Actually, our car raffle is way behind this year. We are about halfway to where we should be at this point. So Deb's getting a little nervous. Other comments, questions, or concerns? Great. Thank you all for coming out. I appreciate you spending your evening.
Thank you, sir.
Thank you.
CCTV for being here.
Excellent. Thank you very much. You and I should talk.
Okay. Anytime.
Right now.
Right now is
Not
good.
this very minute.
Anytime.
In the next 2 minutes.